I had a patient come in due to a seizure that he had, and likely that seizure was due to some of the issues that he's had, plus some sepsis. So I had the problem of trying to figure out exactly what antibiotics I needed to use, and I'd learned partway through the decision that quite a bit of antibiotics can cause these seizures or make it worse. So I wanted to share with you just a little bit of what I had learned. Now, looking at this, I better make certain we understand just the concept. So I'm looking at this like little chart, doesn't really have anything going on with it. We're going to be talking about neurons and how they work, and just in general, make certain we're all on the same page. So when I'm looking at a neuron and how it's working, I need to take into account time, as well as how many millivolts is going through it. Now, what's great about these little neurons is they use electricity to talk, but they don't really talk to each other as long as if their normal charge is below that threshold of -55, which usually they're resting, they're not talking, they're recharging their batteries, like an introvert. They're doing some any type of charge down there is called a graded potential. If they decide to go do something, they go up past that -55 and they get themselves an action potential, which is they're obligated to send a message to their neighbors. Now, how do we play with that? How do we do things like that? So we got ourselves down here below in this graded potential area. We could be sending in some excitatory signals via like letting sodium into the cell or letting calcium in at the end of the cell to say, hey, let's do this. Let's drop some signaling molecules. Let's have some fun. Or the reverse of that, an inhibitory signal. Usually that's where chlorine is let in or potassium is let out. Now, we can cause that signaling to happen by either like excitatory and inhibitory signals. The ones that I care about for this one right now with the seizure stuff is glutamate, which I can send to cause excitation and send some sodium in, or I can send out some GABA, which is going to let chlorine in, which is going to be inhibitory. Now, what's happening with seizures is, or what we're caring about here, is that most of the time we got some inhibitory inhibition. So all we got really is like excitation signals being on the free run and just sending off those action potentials as they wish or unintentionally so, which and usually in seizures that causes a longer action potential, which can send too many signals off and make a bunch of neurons up in that cerebral cortex most of the time overshoot, get the seizures going, the absence, and all that good stuff. Now, the antibiotics, forgive me, that can cause seizures is the beta-lactams, the fluoroquinolones, isoniazid, metronidazole. Now, I'm going to be talking about how that happens, except for metronidazole, because really the mechanism isn't really known. So this is all just one of those things is like metronidazole. It just causes seizures. Fancy. Talk about beta-lactam-based antibiotics. You're going to notice that they target those cell walls, they insert themselves in, and then they make it possible for that bacteria or whatever is being targeted to be able to build a good wall and make itself die. There's like 4 different classes I care about right now. The penicillins, you're going to notice that this thing mimics the cell wall but stops it from growing. The cephalosporins, the monobactams, and the carbapenems. Now, what's happening is, or can happen with this whole seizure stuff, is that those beta-lactam rings can actually insert into these GABA receptors and be a competitive inhibitor. Like they're basically saying GABA go away, but it's not really stimulating an inhibitory effect. It's just shutting down its whole pathway, meaning that you're going to get a bunch of more of those excitatory signals going on. So if I'm looking at these beta-lactam antibiotics and seeing exactly what types do the most or have the most potential to be doing seizures, the carbapenems are definitely the ones that you want to really worry about the most, especially imepinine, which is estimated to cause 3 to 33% of patients, irregardless if they have pre-existing conditions of having a seizure or not. Penicillins is the next highest. Usually it's dependent upon you've been giving somebody a high dose. They can't clear it from their kidneys or their liver's not doing so good to destabilize it or knock it out. Of course, there's always one medicine that's always like an exception to the rule, and that's Pen G for this one. It doesn't matter the concentration you got if you're just predisposed to have it because of it, then you're going to have it. I'm going to move over to monobactums and say it's the least likely because the cephalosporins are a little bit, well, depends type of situation. How it depends is, well, first I should tell you that cephalosporins, if they're going to develop symptoms, it's going to be the first to the 10 days after. And you're going to see like some neurological issues, not just pure seizures. You might see some confusion, fine tremors, all that stuff. Now, if you do see that, just pull them off. Usually the symptoms resolve in a few days and you're good to go. No harm, no foul type of thing. But here's the rule of thumb to help you understand exactly what cephalosporins are the most potent, while the ones, some of them aren't so potent. It's just the addition of rings on position 3 and 7, which, if you're thinking organic chemistry, I'm so sorry. It's like bringing back terrible, terrible memories. But just to make your life easier, there's carbons are labeled by number, by importance, and these are the two right here on a cephalosporin, the 3 and 7. So if I put a ring structure on one of these things, then I'm going to have myself more of a chance to cause issues. So looking at a first gen cephalexin, I got myself a first gen. It's not very likely to do it. You're going to notice that at position 7, there's like a little benzene ring there. Not big deal. But if I go down to another first gen that has 2 rings in it, it's become more likely. The one cephalosporin that's really likely to cause it, or is really well associated with seizures, is cefepime, 4th gen. And notice those rings. They've been bedazzled with all sorts of things. Now, of course, like I said, there always seems to be an exception to the rule, and that one here for the cephalosporins is this 3rd gen ceftriaxone. It's not really likely to do it. Look at those beautiful ring structures, but it's not as potent. So, like normal patients could be just fine, but those of you that have like a risk of having seizures, perhaps choose a different medicine other than ceftriaxone, if possible. Now that's the beta-lactam-based stuff. Let's go to the fluoroquinolones. Fluoroquinolones does something a little bit similar, but it's targeting the GABA B receptors. And they do a little bit of mimicry going on. So here's my GABA. You're going to notice I'm going to circle here shortly. There it is. I'm going to circle here. Hey, look at that. That looks an awful lot like GABA right there. So what they do is they latch on to that GABA, those GABA receptors, and they basically say, GABA, go away. We're not going to let you do your inhibitory signaling, which is no bueno. But then it also, if you add on NSAIDs or theophylline, you can also potentiate these fluoroquinolones because these two will actually attach to GABA A rather than GABA B, which means less inhibitory signals can make it in, and more likely you're going to have your patient a seizure. One last medicine that we should talk about that does and can cause seizures is isoniazid. It can inhibit conversion of glutamate to GABA, which is pretty important, but it inhibits it via stopping the cofactor, the creation or use of cofactor vitamin B6. If you block off vitamin B6, you can't really make GABA. So GABA drops, you lose the inhibitory signal, but you also gain a lot of glutamine, which can make some of that glutamate, which is no bueno. It can make it more excitatory when it's trying its darndest to make as much GABA as possible. So what's the take home? What's for the clinical notes? If you have patients that have some type of seizure disorder, consider some alternatives. There's some doxycyclines, macrolides. If those bacteria, those little buggers, can deal with or are susceptible to doxycycline macrolides, perhaps consider that instead. If they aren't susceptible, maybe they're resistant to those, but they're more susceptible to like penicillins or carbapenem, then just be careful with the dosing. Because especially in patients with renal or hepatic impairment. Because again, you're trying to watch, you don't want those doses too high. And if your way of getting rid of it, clearing it via kidneys is gone, or metabolizing, like aka through the liver, or putting out into the GI system, aka through the liver, is gone, then you're going to have higher concentrations hanging around. And of course, also watch for those CNS symptoms. Watch for that confusion, myoclonus, tremors, all that good stuff. And absolutely be certain that you're not playing with some drug interactions. Make certain you're not doing some NSAIDs, some theophylline. And so, summary, make certain with those seizure threshold lowering stuff like the GABA A antagonists or reduce things that reduce GABA synthesis or things like that. Watch out for those beta-lactams, fluoroquinolones, particularly in the beta-lactams, those chirofenoms, and just be vigilant in those high-risk populations.